it would be strange to ignore the fact that it's very strange times I'm talking to you at the moment, and things are changing quite a lot. What's your take on everything that's going on at the moment?
In terms of work and business, well, it's all just shut down.
Yeah.
So, what can we do? We've given away almost all of our PPE. We've got enough for 2 surgeries at each of our 2 centres, just for seeing emergencies. But everything else is gone. No idea when we'd be able to get any back. So in terms of seeing patients again routinely, nobody knows when that might be. And I'm much more relaxed about it than I thought I would be, because I can't change any of it.
Exactly. Yeah.
Not a lot I can do.
Well, there's so many reasons I wanted to get you on this, and I've seen you speak a couple of times live, and I think you're an incredible and very motivational speaker. In fact, one of my favorite talks of yours is on YouTube, and you were doing a talk on drilling on a slope. And
oh yeah,
for me that was incredible.
15 years ago.
Yeah, that was so eye-opening. I think, geez, I know why I've been placing implants in the wrong place for so long.
Yeah.
That's a great thing. If anyone's not seen that on YouTube or got to see you speak, that's a great introduction to Bill Schaeffer. And I was speaking to Ashley the other day, Ashley Latter, and
hey,
do a course with him as well. How's that going? How's that been?
Oh, I love doing that. So I've done a lot of Ashley's courses.
Mm-hmm.
I think if I've done all of them pretty much, apart from his teenager one. And he's helped me so much. And I do his ethical sales course. It's a 2-day course, but specifically for implants.
Yep.
And I do that with Stephen Jacobs. And we've done this, I don't know, 5 times maybe now.
Okay.
And it's just fun. It's fun because Stephen and I, we do good cop, bad cop, kind of this is how you shouldn't do it and this is how you should do it kind of routines. And they're just fun.
Good to hear. And one of the things you've recently done, which is such a shame, is that you and Stephen Jones have stepped down from the ADI committee.
Yes.
Which is very sad for the ADI. And what led you to take that step? Why are you stepping back at the moment?
I've done it for a long while. I first joined, I think it was 2007, 2008, maybe.
Okay.
And I've done 8 years.
Mm-hmm.
I had a 4-year break in the middle, and that's enough. That's fine. There are younger, more energetic people to step up and step in.
Yeah. And what do you think about the direction it's going in? It seems to be kind of growing in numbers and members.
So I have a very soft spot for the ADI, and it's just been very, very well managed. These have been really tough years. There have been some very big issues they've had to deal with, but they've done it very professionally. It's now an exceptionally well-run operation.
Yeah.
And you've got some very energetic people in there.
Yeah. But one of the things I see that you're moving away from doing and moving towards, maybe I should say, is you're moving towards short implants now, or you've been doing it for a long time.
Been doing it for a while.
Yeah. And they work, and they work in the posterior maxilla in your hands as well, do they?
So I was kind of my first implant system.
What would you define as a short implant? Let's start with that.
6 millimeters or less.
Okay.
I've placed many hundreds of implants that are shorter than 8 millimeters long. Many hundreds.
Yeah.
And they work just as well as other implants do. So whilst you're very scared about the first few you place, after you've placed dozens that are fine, you get less scared. Yeah. Now it just doesn't concern me.
Yeah.
It's of no consequence. An 8 millimeter implant for me is not a short implant.
Wow. So if you had as much bone as you wanted, what would be your ideal length of implant? If you could pick anything, would you probably wouldn't pick a 6 millimeter if you had 30 millimeters of bone, would you?
Why not?
I don't know.
It depends on what you want to do. There are things for which short implants do not work well.
Okay.
Immediate loading.
Right.
You might not put a 6 millimeter implant in if you're immediately loading it with a crown.
Yeah.
Immediate implants, placing them into sockets. the top of the socket is all air.
Yes.
You know, you want to engage some bone further down, so you probably wouldn't place a short implant into a socket.
Mm-hmm.
And those situations where you've got a very thin ridge and you're going to do GBR around the implant at the same time, you know, the top half of the implant isn't going to be in bone on one side. So you want a longer implant so you can engage some bone deeper down, even as you graft over the top exposed threads. So those are three situations where you might want to use longer implants.
Right.
Other than that, why use a longer implant?
I mean, to be honest, I wasn't expecting you to say that, so that's very interesting.
So we look at everything in our center. We have 6-7 surgeons now. So we look very closely at what they do, at problems they have. And in a healed site, the most common, in fact, for any site, the most common implant that we place by far, is an implant that's 4.5 millimeters wide and 6.6 millimeters long.
Wow.
It's an Anklos B6.6.
Okay.
By far, maybe 2 or 3 times, we place more of those implants than any other size of implant.
Okay. And so
give me 30 millimeters in any position.
Yeah.
And a B6.6 will support anything.
So does that mean you're placing mainly in healed sites? You're not placing as many immediate implants as some people would?
So it depends on where you're talking. I love placing immediate implants. And, you know, I want to help the patient quickly. I want to take the money quickly. So if I can do the treatment quickly, that's great for the business.
Okay.
I know a lot of people who do immediate implants in molars, and I've done that. And you know what? It's just a bit stressful.
Okay.
And what I mean by that is, you know, yes, even if you use denser burrs and you go through the little bit in the furcation, you widen it out and you stick an implant in, you've still got to graft the rest and you've still got to somehow get closure.
Okay.
You know, it's just, why not just take it out, let it heal, go back into the stick an implant in, that's nice and easy.
But you've done the Estevan Urban Regenerator course.
He went on a 3-day course.
Yeah.
And as soon as I finished the 3-day course, I booked on his 9-day regenerator course this year. Now, whether it's going to go ahead or not, I don't know. But he's great. Now, like anybody doing a treatment, he does things that I would put a short implant for. So he's very, very good and very predictable at doing big grafts. Mm-hmm. So he will graft things that I would put a short implant in for. Now that's fine because he does them really well. Mm-hmm. But like anything, you have to kind of take from these courses the things that are going to be useful in your practice. Okay. So if you go to Prof. Curry and do his plates course, you're going to come back thinking you've got to plate everything. You don't.
Right.
It's Van Urban's course. You've got to do vertical grafting for everything. You don't. You've just got to take the things that you can use for your practice and do those.
Fantastic. Yeah. And so what courses have you done over your career that you thought, along with the Estevan Urban course, were fantastic courses? I mean, there's a lot of implant courses out there.
There are.
That stand out to you that you've done?
And you know what? You know, I've done bucket loads. The most useful one for me was Ashley Latter.
Okay.
It's not a clinical course.
No.
But unless you can get the patients to say yes to treatments, all your clinical courses are a waste of time.
Yeah. Okay. And you said you obviously, I'm guessing you do quite a lot of full arch stuff where you are to take on some of the more challenging cases. Do you feel that that is something that people should move on to with caution? You know, so I think there's a lot of young dentists who feel probably a pressure looking online at the moment to be thinking, well, this is what everybody's doing. This is a very mainstream treatment. And what's your views on that? Do you think, yeah, it's pretty straightforward, or do you think I would recommend staying well away for a while?
So the simplest implant treatment is a single implant in a healed site.
Mhm.
And then there's a graduation of increasing difficulties through to multiple implants in healed sites, implants in sockets, immediate loading,
Mhm.
implants in the aesthetic zone with a low lip line, then with a high lip line,
Mhm.
bridge work, bigger bridge work, full arch work, full mouth work. And so the kind of the hardest treatment is going to be at the harder end of that spectrum, high lip line aesthetic cases and full arch cases.
Yeah.
They're bloody difficult.
Yeah.
Anybody can stick an implant in a high lip line aesthetic case, but it's really, really hard to do it well.
Yeah.
It's really hard to get it right. Anybody can do a full arch case.
Yeah.
Anybody. It's really hard to do it well.
Okay.
And do it right and have it work.
Mm-hmm.
It's really hard to do it right.
Yes.
We only have very experienced surgeons coming and working with us.
Okay.
And then they have to go through a big bit of mentoring with us.
Mm-hmm.
And then when they come to us saying, I want to do a full arch, we make them present to us before they're allowed to do it.
Okay.
And when they do it, they have one of the experienced people kind of shadowing or looking over their shoulder. And they always make mistakes. They always screw stuff up.
Okay.
And these are really experienced implant dentists.
Mm-hmm.
So yes, the when you go on a course like Ish Van Urban or Prof. Curry or Zucchelli, you see them do stuff and they make it look easy. It's their job to, because they're doing it all the while. Yeah. You go on Facebook and you see wonderful stuff done and they make it look easy. It's not easy, it's bloody hard.
Tomorrow I am speaking to Victoria Holden about
brilliant, yes,
getting out of trouble and getting her views on how we can do that. And one of the things I wanted to talk to her about is this kind of heterogeneity almost in the way that we assess implants in this country. And you're on the ADI forum and you'll see some of these discussions where people saying, you've got to probe, you're crazy to probe. What's your view? Or how do you, let's widen that, sorry. What do you do when you're maintaining an implant and on recalls?
Sure. So if you've got a dentition without any implants, mm-hmm. if you don't want to find any perio problems, don't probe.
Okay.
All right. But that would be negligent. So we probe. Probing around a healthy tooth mm-hmm. is not painful, does not produce any bleeding on probing. Massage the gum, there's no discharge.
Okay.
It's no different around implants. If you don't want to find any pocketing around implants, if you don't want to find any peri-implant mucositis or peri-implantitis, don't probe. It's fine. If you do want to try and spot stuff early, why would you not probe? Now people say, oh, it's a different attachment, this, that, and the other. Probe the damn thing.
Yeah.
People say, oh, you must use a plastic probe or a special probe or a titanium probe, or just probe the damn thing. Yeah. Use your normal probe, probe it.
Thank you. Right, okay.
I probe.
Yeah, yeah.
I also take lots of X-rays.
Okay. And what's your X-ray recall? I mean, how often would you X-ray an implant, or do you recommend your referral dentist to X-ray your implants? At what stages?
So we take an X-ray when we fit a restoration.
Mm-hmm.
We take an X-ray 1 month later.
1 month, okay.
We review them 1 month later and we take an X-ray then.
Okay.
Because strangely enough, it shows up problems sometimes.
Okay.
We then see them after 6 months and we then see them yearly.
Yes.
If after 5 years everything is nice and stable, we then see them every 2 years and we take an X-ray every time we see them. So I have a very low threshold for, well, I have no threshold for probing and a very low threshold for taking X-rays to check the bone levels around implants.
Great. So thank you very much for taking the time. This was